Just a brief little talk here about the disabled athlete. A lot of these topics could be very expanded upon. So I tried to pick some of the more high yield things. Um, no disclosures to report. Okay. Objectives for today. The goal is to define the disabled athlete and adaptive sport spectrum, describe unique biomechanics and injury patterns that we'll see with this patient population, albeit broad, identify key medical and safety considerations for us as providers to consider, as well as apply principles that we discuss for said key medical and safety considerations to things like personal protective equipment, injury management, and return to sport. Why does this matter? In terms of athletic populations, it's one of the fastest growing. U.S. Census data from 2023 actually shows there there to be approximately 44.7 million people in the country to have some form of disability, 13.6%, with approximately 44 to 49% or 46 to 49% of those engaging in some form of physical activity. Now, a lot of what we'll focus on is more of the elite athlete here, but these principles can be used for all athletes, from the Paralympic to the adaptive to the recreation athletes, just like we talk about with our able-bodied athletes. Paralympic sports have become more and more popular, with summer games most recently having 4,500 athletes in over 20 sports, winter games having 500 athletes in 5 sports. And unfortunately, this is both very underrepresented as a patient population as well as in our training. There have been studies that show that emergency medicine residents get approximately 2 hours of training a year on disabled patients, let alone disabled athletes. And these disabled athletes, while they represent a diverse population here in the United States, is relatively, because we live in a relatively affluent country that's much underrepresented in places with low and middle income countries. Majority of the patients here in the United States are going to be white, approximately 85 to 87%, and male. But key thing is, what is a disabled athlete? And there is a difference between in the definitions here between an impairment and a disability, although they're somewhat interchangeable in our modern day, like our vernacular. An impairment is an issue with a body part or function. And a disability is the difficulty in performing a specific task or activity because of said impairment. So, for example, you think of somebody who has an amputation, that is their impairment. Their disability is the ability to ambulate without a specific assistive device or as like an able-bodied person. So just keep that in mind. A lot of times it gets kind of switched back and forth. And even myself, I have a hard time sometimes keeping the two straight. Technically, there are now 10 impairment groups. It depends on what governing board you're looking at. Of the 6 main groups, there's like under the number 4, you'll see there's like a bunch of other ones that kind of create 10. Spinal cord related issues, cerebral palsy, amputation or limb deficiency, I'll say other physical impairments. Okay, this is going to be things like limb deficiency without amputation, neuromuscular and musculoskeletal conditions, congenital conditions, and don't forget visual impairment and intellectual impairments. Okay, going to be a difference here between congenital and acquired, not in just the medical sense, but also in the psychology sense, in the ability for your athlete to perform initially in some of these sports. So congenitally disabled athletes typically start participation in sports much younger than compared to acquired, just by the nature of their impairment. But funny enough, it hasn't been shown to change much in terms of career milestones. So people who really commit, who have acquired impairments and participate in sports do tend to um, rapidly improve. But the congenital onset does predict a higher satisfaction with sport life among athletes, and they have shown a stronger impairment or disability identity as well as self-efficacy, most likely because acquired disabilities, they have to adapt to their new impairment and their new change in physical capability and identity. Um, Elite versus recreational. Elite impaired athletes or disabled athletes tend to have better health overall in comparison. So fewer injuries. They lose fewer training days to injuries. They have shown to have better sleep quality, lower stress, higher well-being scores, and better compensatory mechanisms. So we'll talk a lot about the cardiovascular changes that happen with some of these patients, or like the metabolic changes that occur with certain diagnoses. And more training, more physical activity seems to be a protective factor for these. Okay. Almost similar to able-bodied athletes. But I think the key concept here is impairment or disabled doesn't mean you're unable to train, or I should say compete, not complete. Okay. So the adaptive and Paralympic sport overview is important here because a lot of these set the universal codes and standards for all the sports that they kind of umbrella. Okay. So they set the standards in terms of the Summer versus Winter Olympics, what adaptive equipment is allowed to be used, what eligibility a patient has in terms of their impairment, and how that's the requirements there. So these are just a few of the governing boards, like the International Paralympic Committee, the International Sport Federations, the National Paralympic Committees. Okay. And an athlete must have a certain permanent impairment or that fits into one of the International Paralympic Committee's subtypes. Okay. And each one is going to have a minimum impairment criteria, which we'll go over in a second, as well as a sport class. And that allows the athletes to be grouped so that things are fair. So, for example, in wheelchair basketball, they use a point-based system based off of trunk control. So class 1, you're going to have little or no trunk control, and you're going to require your arms for support. Class 2 is going to have some trunk rotation, but limited forward leaning. Class 3 is going to have full forward and rotational movement, but have difficulty with side bending. And then class 4 and 4.5 are almost full trunk movement. And each one of those is given a point system, and per team, you're only allowed to have 14 points on the court at one time. Okay. Why does this matter? Okay. Fair competition. All right. Matching athletes based off of their functional ability and impairment severity minimizes the disability or the impairment and maximizes the skill for sport outcome. Okay. So we want to make sure that these athletes are participating and have a chance for competitive success on skill rather than the differences in their impairment severity. Okay. It's both a medical and functional classification, and my next slide will go over that for two classes. And athletes have actually sued medical providers over this to see what class they should be a part of, because just like any other athlete, always trying to get some competitive edge. Okay. And it's also important because it has an impact on both the biomechanics, the training loads, and the injury risks. So for example, athletes with visual impairments, they have and neuromuscular disorders, they show the highest injury compared with athletes with brain disorders such as previous TBIs. Vision disorders, they have been shown to have evidence of 13.7 injuries per 1,000 athlete days. Okay. And these are going to be mostly acute lower limb injuries versus neuromuscular disorders. It's going to be mostly upper limb injuries, and brain disorders are going to be much less at 9.1 injuries per 1,000 athlete days. The majority of these are going to be upper extremity, and we'll talk quite a bit about that in a second, representing about 19 to 20% of all injuries for the disabled athlete. But this doesn't have to be, the classification doesn't have they have to have a permanent impairment, but that impairment can change throughout their lifetime as they adapt, as they get stronger. We know that in medicine, things aren't always black and white, so things can change throughout an athlete's lifetime. This is an example of a classification system. So on the left is like what's considered the T50s. It goes over like T51, T52. That's like restricted upper limb movement, restricted abdominal movement. T54 is complete movement from the waist up. And that's for like spinal cord injury. Then you get into the T30s. So T32, T34, athletes who use wheelchair versus T35 athletes who can stand. I'm not expecting you to know that, but it kind of puts the next slide in perspective. This is the times of participants in a 100-meter wheelchair, a 100-meter sprint time. Okay, so you can see there's your participant on the left, your IPC class, your level of competition, their diagnosis, and then the resting spasticity. So there's a lot more that goes into what these athletes are and what they bring to the table athletically before even skill level, just to try and keep things on a somewhat even plane from an impairment standpoint. So this brings us to some of the unique biomechanics that some of these athletes are going to bring to the table. The first one is anybody who's a wheelchair athlete is predominantly upper extremity use dependent. Okay, so their ability to, quote, ambulate or move is going to require a force transmission through the hand rim surface so that they can propulse themselves. And these athletes show a lot of injuries in their upper extremities as a result of this, not just because of the repetitive nature of their sport, but also because of the repetitive nature of their day-to-day activities, or doing their ADLs requires a lot more load and force than an abled athlete who can ambulate. All right. The shoulder itself is going to experience the highest mechanical demand. For propulsion, it's going to be those shoulder flexors. Okay. And then for braking, it's going to be the shoulder extensors. And this force is cyclical. Okay, meaning that during propulsion, the joint power generated through the forearm, they use the hand to propel. So it goes from the shoulder to the elbow to the hand. And then it kind of, as you can see in the graph, it kind of pulls backwards, going from in terminal propulsion, it goes in reverse from the hand to the elbow to the shoulder. And there are different forces depending on the level of impairment. So you think like high cervical athletes or tetraplegic athletes, they're going to have increased superior joint forces at the shoulder, elbow, and wrist compared to paraplegic athletes who have been shown to have a little bit more with the elbow and wrist because they have more control over those joints. Okay. And the force on those joints is increased significantly. So in terms of muscle force, depending on how vigorous, like I said, depending on how vigorous and how high the impairment is, the increase can go from 28 to 71% of muscle load, and the joint force can get up to 23 to 112% more, depending on how vigorous they are pushing and the level of their impairment. And then they have a higher propensity for these injuries, but we as sports medicine providers know these injuries quite commonly in all athletes, but it's just they have an increased risk of them. So in the shoulder, think rotator cuff tendinopathies, pathologies, subacromial impingement, biceps tendinopathies, glenohumeral OA, lateral epicondylitis, carpal tunnel syndrome, all the overuse syndromes and injuries that we see on a day-to-day basis, we're going to see more in our impaired or disabled athletes. We're going to see a lot of asymmetric loading in these athletes. Okay. This is going to predispose them to increase mechanical stress on intact or less impaired limbs. So think, you have somebody who has an amputation or lower extremity amputation, the ground reaction force, which we'll talk in just a slide or two, is different compared to an able-bodied athlete without a residual limb and has their able limb. Okay. And it's going to be, you're going to have altered force distribution for both the the residual limb and the non-impaired limb. And then you're going to have compensatory loading patterns. And these can lead to things such as more wear and tear injuries, osteoarthritis, tendinopathies, as well as acute trauma. Okay. Limb deficiencies are, like I said, are going to be the patient populations that have the majority of these because of the having a residual limb. So if you think, especially during dynamic activities, so you're going to get reduced push-off power in that residual limb that has a prosthesis. You're going to have reduced shock absorption on the prosthetic side. But don't just think of patients with amputations. A lot of these impairments, such as patients with cerebral palsy, you have things such as spasticity and movement inefficiency coming into play. This is going to change your ability to have like your motor control. You're going to have some impaired proprioception, and these dynamics are going to take a toll on the body. So you have a predisposition to not just the overuse injuries, but the acute injuries, because these tissues, muscle are not optimal. Okay, so you're going to have quicker time to fatigue thresholds, exaggeration of any movement inefficiencies that they may have at baseline, and this predisposition has been shown to have a 7-fold increase in injury risk, as well as a 73% accuracy in predicting re-injury of that occurrence. And this, if you look at the table on the left, these are the requirements for energy compared to someone who has 2 feet and able to ambulate without issues. So, you have somebody that has even just a short transtibial amputation, they require 40% more energy to maintain speed compared to someone who doesn't. And that extra energy and requirement on tissues is not beneficial in terms of injury and injury prevention. Okay. A little bit more in depth here about the prosthetic limb force transmission. Excuse me. So, you have a patient with an amputation, they have a prosthesis. The ground reaction force goes through the prosthesis into the residual limb, into the skeleton. The prosthetic limb is not the normal intention for the body. So it has decreased shock absorption, decreased proprioceptive feedback, the joint kinematics of whether or not this is a tibial or a femoral, it's going to change depending on what type of prosthetic you have. And that there's going to be a concentrated force on the socket and the residual limb, that interface, which can lead to things like friction, pressure, and occlusion that all have the ability to cause issues, which we'll see on the next slide with skin. Okay. And then the attack limb on the other side is going to have increased ground reaction forces on that limb, increased energy expenditure, like we talked about before, and increased joint movements at the knee and hip that predispose to these overuse as well as acute injuries. Going from left to right, these are just some common skin injuries or skin issues that can occur. in patients who have in their residual limb. Okay, so 34% of just regular amputees have been shown to have some form of skin-related issue during their time, and then this can increase 2 to 3-fold in athletes. So in amputation medicine, we always talked about making sure that the residual limb was dry, making sure that the prosthesis was intact and fit regularly. And if you think about athletes who are attempting to, push the limits, just, sprinting, shifting, moving, sweating, there's a pretty good chance that they're going to develop some of these issues in their lifetime. So from the left, you just have something simple as as blistering. In the middle, you see things like contact dermatitis. And on the right is a fairly common issue with patients with amputees. It's called verrucous hyperplasia. Essentially, it's like a wart-like condition. You're going to get these rough, bumpy patches, and this is what's caused predominantly by an ill-fitting prosthesis. So you're going to get it's going to get changes in load and pressure and lead to friction. And you're going to get things like poor circulation, which causes venous stasis, edema, which leads to swelling. And these don't include the other, common things that can happen, such as cellulitis or thickening of the skin, like various abrasions, pressure injuries. Okay. Some other unique biomechanic things to keep in mind: brain impairment and running. So those with TBIs, they've been shown to have shorter stride lengths, reduced ankle and hip range of motion, increased ground reaction time, decreased ankle power generation at toe off. We already talked about vision impaired athletes and their acute lower limb injuries, but these are very sport specific and impairment and disability specific. So something just to keep in mind when you're evaluating an athlete. This is more of a doesn't need to be when an athlete comes in for evaluation, but something just to keep in mind. Oh, hey, these are, someone comes in, I'm having pain here, or you're covering an event, just to keep in mind. Okay. And I think that's one of the key things of this talk here is a lot of these are very sport specific and impairment specific. So just things to keep in mind when you're taking care of these athletes. Common training errors are pretty similar in terms of between our impaired or disabled athletes and our able-bodied athletes. So, these are athletes and they're going to do things like rapid volume escalation. They're going to have equipment that doesn't fit based off of, where they are in training, weight, water weight, use of their prosthetic limb, breakdowns in wheelchairs, those types of things, not allowing themselves to have inadequate recovery. The difference is a lot of the times there's not as many options for things like cross training. You have a runner who develops a stress injury in one leg. You put them, it gets really bad, you put them in a boot, you tell them, hey, like, let's lay off of it. Well, you have people with spasticity and they're trying to run and they've got their one able-bodied, like their one good residual limb. It's going to be very difficult, not just from a training standpoint, from a life standpoint, to put them in a boot, and have them use like a wheelchair, stuff like that. And something to keep in mind is that their daily mobility and sport are combined. So a lot of times wheelchair athletes, they're not just in a wheelchair just for sport. They're also required to be in a wheelchair for day-to-day activities. So when you have things such as rotator cuff pathologies, you need to know that, hey, this could also be affecting like their transfers or their ability to take care of their ADLs. Okay. Big picture wise, overuse injuries tend to be more prevalent than acute injuries, upper extremity predominance, and multifactorial pain sources. So very common for impaired athletes to have neck and low back pain, especially in wheelchair athletes. This tends to be very multifactorial. We already talked about like various asymmetric loading patterns, compensatory patterns, obviously sport-specific repetitive stressors. But for wheelchair athletes, you're going to have a lot of large lateral flexion and bending due to impaired core musculature and maintaining a posture. We talked about the repetitive upper extremity movements. Well, a lot of that's going to be in the shoulders, and you know, we talked a lot about our able-bodied patients about maintaining good posture through strength in the retractor muscles of the shoulder girdle. Might not be possible for them because they need that musculature for movement. Premature osteoporosis or breakdown, especially below the lesion. Okay. Postural fatigue is not going to be seen just in spinal cord patients, but also in spastic patients, so cerebral palsy, neuromuscular disorders, and then those sport-specific repetitive movements, very similar to our able-bodied athletes. You have, you know, throwers who are constantly doing the same motion. You're going to get over growth of certain muscle groups and can lead to, you know, breakdown in kinetic chains and on all that. So nothing specific here, just be cognizant of different movements of whatever sport they're participating in. Some high yield or medical and physiologic considerations. We won't go through all of these, but only three big ones. So autonomic dysfunction. So think autonomic dysreflexia, cardiovascular differences based on the level of injury, impairment and thermoregulation, increased, or we'll talk about something a little bit more, I think, spot on, than increased energy expenditure, osteoporosis, seizures, and bowel bladder dysfunction. Okay. So autonomic dysreflexia, it is a life-threatening emergency. Okay. This is going to be mostly seen in patients with spinal cord injuries at or above T6 due to the breakdown in the sympathetic system. Or parasympathetic, excuse me. It's a sudden increase in systolic blood pressure of greater than 20 millimeters of mercury above their baseline. So, you know, at that point, it's not, you know, a normal is not 120 over 80. If their baseline is 90 over 60, it would be 110. So the pathophysiology is uninhibited sympathetic discharge below the lesion. This is most commonly seen with noxious stimuli, about 80% bowel or bladder issues, pressure injuries, tight clothing, cuts, procedures, those types of noxious stimuli. The clinical presentation is going to be severe hypertension, headache, flushing, and sweating above the injury, piloerection, blurred vision, anxiety, and when severe, can lead to stroke, seizure, MIs, retinal detachment, death. It's essentially a sympathetic overload above the level of the lesion. Treatment is typically removal of said noxious stimuli, stop whatever activity you're doing, or you can do things like a short-acting antihypertensive, and we'll talk a little bit about that in just a second when we're talking about our action plans. The unique thing is that athletes were always trying and find some kind of competitive edge, and there is a phenomenon called boosting, which essentially is spinal cord injury athletes actually intentionally induce AD so that they can get that sympathetic overload and increase their blood pressure, in a sense as well, their blood flow to working muscles. This has been banned for over 30 years now by the IPC, but it has been shown to increase in outcomes. So there was a study in 1994 that showed that wheelchair racing, people who induced AED by overloading their bladder, they were able to increase their times by 9.7%. And so it's still, and it can be hard to diagnose and enforce, but it is illegal. So something to keep in mind if you are ever doing an event like this. Thermoregulation impairment, similar to autonomic dysreflexia, especially in spinal cord injury, there's a loss of vasomotor and pseudomotor sympathetic control below the level of the injury. Okay. There's a lower incidence, but this can also occur in cerebral palsy. So if you have inability to regulate the sweat glands and blood vessels in combination with anticholinergic medication, this can also happen. Okay. The level of the lesion for spinal cord patients is going to be the key factor. So anybody, like the higher you go, the higher the risk. So cervical is going to have the fastest increase in core and skin temperature versus high paras in like the high upper thoracic spine and low paras in the lower thoracic and lumbar spine. Um, Clinical implications of this is going to be the risk of exercise-induced hyperthermia and post-exercise hyperthermia, because you're not getting that vasomotor and pseudomotor control to actively cool the body, as well as the phenomenon known as poikilothermia, which is where the body temperature tends to ebb and flow with the environmental temperature. So if you're having patients in very cold environments, their risk of hyperthermia goes up much more, because their body's compensatory their compensatory actions doesn't occur as well. Management. So there have been studies that show that different heat acclimation protocols can actually help to mitigate this. So they did a study on implementing like a 7-day heat acclimation protocol. So essentially, hand cyclist athletes with high cervical spinal cord injuries would do 1 hour of training at 50 to 60% of their peak power over 7 days, and this improved their time to exhaustion, their sweat rate, as well as any body mass loss. Okay, having access to pre-cooling, readily access to fluids, and then appropriate clothing for whatever event they're participating in. These are other ways that you can kind of help mitigate. Increased energy expenditure. That's what a lot of the literature kind of describes this as. I think it's more as suboptimal energy expenditure. So you're going to have things like movement inefficiency, reduced muscle mass, impaired autonomic control, some of which we've already talked about. But these require, reliance on assistive devices, wheelchairs, crutches, canes. And while this calorie expenditure may not be the same as able-bodied athletes, the proportion is actually still increased. So for once again, looking at spinal cord patients with hand cyclists or hand ergonometry in terms of wheelchair or hand cycling, they may only utilize, up to like 400 kilocalories an hour at sustained intensities, which is much less than an able-bodied athlete doing the same tasks would expend, but that is much higher percentage of their max capacity for energy expenditure. Okay. And then there's there's a description of this reduced metabolic reserve. Okay, so a metabolic squeeze, so to speak. So essentially, things that wouldn't affect an able-bodied athlete as much do, because they have higher submaximal energy costs, up to 15 to 20% more for an impaired athlete, as what in combination with a lower cardiorespiratory fitness compared to other peers. Body fat distribution. So patients who perform approximately 150 minutes a week, 38%, it's been shown that on average 38% body fat in patients with spinal cord injury versus 28% of able-bodied or non-spinal cord injury or non-wheelchair bound patients. Okay. Lower energy availability. All right. So you're going to have a reduced resting metabolic rate, decreased fat-free mass. We've already talked thermoregulation, energy demands, and overall weaker muscle strength in comparison. So, there are going to be stronger muscles, but especially in like the shoulders, as we've already talked about, in like wheelchair athletes, but this is overall in comparison. Okay. Which makes moderate to vigorous intensive activities difficult to maintain in combination due to accelerated fatigue. All right. So sideline coverage, pretty similar in terms of between the impaired versus the non-impaired athlete. And just knowing what you're covering and what things these athletes can be predisposed to. Okay, so having good emergency action plans that are more catered or specific to these athletes. So, for example, you're doing wheelchair basketball or wheelchair racing and higher cervical injuries, knowing that the propensity for autonomic dysreflexia is higher in these patients. So making sure you have something like a short-acting antihypertensive on hand on site, such as nitro paste or any a beta blocker, those types of things. Sign language for your vision impaired athletes, making sure you have an interpreter there who can help you out. Okay, things like cold water immersion tubs that we typically see in long races you might need at your event. Okay. Having specialized safety equipment, okay, things like slide boards, just so you can evaluate a patient who's in a wheelchair and get them onto a table versus having to do it inside their wheelchair. Okay. Accommodating medical stations. So the assistive device in and of itself is a part of the athlete. So making sure that you have equipment such as like wrenches and screwdrivers that can help with things like your wheelchairs, power chairs, and charging apparatuses. Okay, because for these athletes, they're assistive devices, and if they're or equipment failure, that becomes a medical issue for them. Transfer safety. So like I said, slide boards or even simple things like making sure medical tents are easily traversable for whatever athlete you're taking care of. Okay. As well as environmental considerations. We already talked about the risk of like thermoregulation impairment. So, it may be an overcast day, but for high cervical cord, spinal cord injury patients, you're still having a risk of autonomic issues. Okay. Personal protective equipment and clearance. The difference here is, it's not just, hey, an able-bodied athlete, oh, hey, like my cleats don't fit very well. A lot of times this is it's essential for their sport. So a functional assessment can sometimes be even more important than our standard ortho exam. Okay. As well as equipment evaluation. So making sure our prosthetics fit correctly, making sure the wheelchairs limit pressure injuries, as well as fit whatever sport federation or sport committee is required. Okay. Similar to able-bodied athletes, skin checks. If you've ever done like a wrestling tournament, they have various protocols and stuff for that. It's going to be more important for these athletes because they are more prone to things like pressure sores, friction blisters, fungal infections, and dermatitis. So you have to be very cognizant of not just the area where an amputee where they meet their residual limb meets the prosthesis, but also if you're the sacral area, the elbows, anything that can rest or grind against like a wheelchair. Okay. Cardiovascular screens. So not just our typical screen. You have patients that can have congenital heart defects, like AV septal defects and Down syndrome, which may require cardiovascular evaluation. Or if you are in a contact sport, looking, hey, do we risk having a patient with Down syndrome participating, or should we investigate further? You have to kind of cater specifically for each impairment or each disability. Return to sport principles are going to be more function based, not specifically time based, and individualized. We do this pretty well, at least here. But you're going to have more of a multidisciplinary approach in, an athlete's medical team here. An able body will, have everything from physicians, ATs, PTs, the works here. But in impaired or disabled athletes, you're going to have other members of the team. And a lot of times that has to do with their prosthesis or their wheelchair. So things like orthotists and prosthetists are going to be essential, as well as people who help with wheelchairs and like maintaining as well as fitting of these wheelchairs are going to be very, very helpful in keeping these athletes back in the game. Okay. And then consider, and if you take one thing, consider not just the sport, but also their daily living demands. Okay. So there are the disadvantage of these is a lot of the movements and stuff that these athletes do, they do require in day-to-day living. Okay. Key takeaways for this: disabled athletes are and can be high performance athletes. Okay. Their injury patterns are going to reflect different biomechanics as well as daily function mechanics that can be repetitive. All right. Personal protective equipment and return to sport. These do require adaptation, not necessarily exclusion, and think athlete first. I know we try and do that with all of our athletes, but specifically our impaired or disabled athletes. And here are my citations. Any questions?
Yeah, nice job, Kyle. That's a very comprehensive overview there of the disabled athlete. Obviously, you can give multiple lectures on each of those topics. I think the important thing for the residents and the fellows, the autonomic dysreflexia, that is a very common test question. And honestly, for sideline coverage too, if you guys are doing any para para athletic coverage, I think it's really important that you're aware of autonomic dysreflexia. People that are doing it unintentionally and obviously for boosting as well. If you're covering the higher end or higher level, sorry, sports. So knowing how to treat it, knowing how to recognize it, that's really important from a testing perspective, right? They like to point out T6 and injuries at that level. They're going to be more susceptible to it. And then you commented on the pre-participation exam too. They'll ask you guys a lot of questions on that and the shift that has changed with our Downs athletes and atlantoaxial instability and whether or not you get you get cervical films before they compete, which you don't know, which you no longer need. So, and then the biomechanics stuff, which was really nice. A lot of that was really, I think you outlined it very well, which was great. Any questions or comments for Kyle? All right. I expect everyone on this call then to be ready to cover some adaptive sports.
Just my own
Um,
little plug. If you're interested in participating in like any coverage, most of these governing bodies will take physicians. Back in residency, we used to do adaptive surfing, which was awesome. It was a great experience. It can really open you up to different aspects of medicine and even sports medicine. So if you're interested, you can reach out to me. I haven't found anything here in Michigan, but I'm sure it's around.
oh, there's definitely stuff around. I even have a patient that was doing some wheelchair basketball too, which is kind of fun. I think most people that are not comfortable with taking care of adaptive athletes like that, I think more of it's just a knowledge gap there. And I think having more lectures like this is really important because, as you mentioned, there's just more and more athletic opportunities, which is excellent, which is what you want. And so, just making sure that our familiarity increases as physicians to give us that option if we wanted to cover it. So, a nice lecture. Okay. I think we will move on to our next lecture, which is going to be Dr. Bechet.
Hey guys,
I believe you are the co-host, so you can
let me
start whenever
share.
you like. Thank you for joining. Thanks for giving us lectures.
Oh, my
They're
pleasure.
always great.
No, you're very kind. So today I'm going to speak on irreparable rotator cuff tears. So often we see these. It's pretty common for a sports surgeon to see these, even sports medicine non-op, and wonder what are our options. And I think like the last lecture, some of it is just what to do and knowing what's out there, that there are other things other than a reverse total shoulder arthroplasty, and that we can make these people feel a lot better with some other options. When you're looking at rotator cuff disease and tears, these are the different options we have. We have partial tears, which are those pasta or paint lesions. We have full thickness, and the definition of these is the small, medium, large, and massive when they're greater than 5 centimeters. But some massives are repairable. So there's a difference between a massive and an irreparable tear. So we're going to concentrate today on these massive, the greater than 5 centimeters, and then into the irreparable tears. So we have this menu, and it's this continuum of care of whether we start with conservative treatment, do we debride, do a tenotomy and rehab. That's something that was started years ago by Rockwood. He would do this open in the early 70s, and patients actually had decent outcomes just cleaning up everything and doing tenotomy, getting rid of the biceps pain, and just starting some therapy and trying to re-register the shoulder. One of the things you see here is an unregistered shoulder, and what I mean by that is when you look at the glenohumeral joint, there's superior migration. At that point, it's unregistered. It's sitting out of the joint. Every so often, you see these massive tears with a registered joint, and those are the ones that you'll see, and they'll have range of motion, they'll have function, they'll just have weakness, and sometimes they'll just have pain because of the issues with the shoulder, but still have good range of motion. We'll talk about that in a second. We can do repairs and augment these. There's a lot of different augments, and with the clinical guidelines being changed by the Academy this year, it's been really interesting to see how everybody's pushing towards augmentation now because it's been shown that it actually this if there's something to do, it's to go ahead and augment, and that dermal allograft is no longer the standard of care. We'll talk a little bit about bridging, which is where essentially you take the end of the tendon and you sew an allograft to it. So essentially you're extending the tendon. Pretty difficult to do, but the studies are pretty good when you can do it, especially arthroscopically. SCR or superior capsular reconstruction kind of going away. Subacromial spacer, not what it we thought it would be, and then so the latissimus and lower trap transfers, and of course reverse. So are the predictors that we can see in the office and right away know this is a repairable or irreparable tear? Well, in this study by Professor Gerber, 33 patients looked at them 2 years after repair. What he realized is if you had grade 2 or 3 Goutallier changes and less than 15 millimeters of supraspinatus tendon length, you had almost a 100% failure rate. If the tendon was greater than 15 millimeters with no fatty infiltration, it was less than 25. So what that's saying is maybe we still don't know what we're doing with our repairs and how to do it. I think we're evolving, and we're hearing that these days with a lot of the new studies coming out, because the rates of failure remain very high, even with a patient with no fatty infiltration and a good looking tendon. But I think one of the most important things to look at is this particular view when you're looking at your MRIs, your T1 sagittal view. And what we want to see is in this Y, we want to see that about 50% of our rotator cuff muscle, in this case the supraspinatus, is above what we call the tangent line. And the tangent line sits from here to here, right? From the one Y to the other. So we want to see muscle here. If we don't, then we can be confident that that's probably not going to heal. Not to mention, you see some infraspinatus issues there too. So I always kind of equate it to a good piece of steak, and that's how I explain it to my patients. You would never want to eat this steak on the right. I apologize to any vegans on this call, but you want it to be more over here. And if you see a good, healthier muscle, those are the ones that are going to do better. So we really need to understand the Goutallier classification, because this is how we're going to communicate with each other and say, hey, I have a big tear, 3 centimeter tear, grade 3 changes. All of a sudden, you start putting it all together. And how can we use that to come up with a way of really understanding if it's fixable or not? The Rohe index, which is this rotator cuff healing index. And it's very simple. It's very easy to do. It's like you look at their age, you look at the AP tear size, you look at the retraction, you look at their infraspinatus fatty atrophy. It asks for bone mineral density. Oftentimes, you don't even need to get to those numbers before you really have a good idea of where you're going to go with this. And then the level of work. And then you just plug and chug. Once you put all these numbers in, and there's a couple apps you can download that you can do it right there. And it usually will tell you if this is, the percentage of healing in this. Less than 4 has a 6% failure rate. Greater than 4 has 55%, and greater than 10 has 86% failure. So when you're seeing some of these patients and they come in and they're like, I want to repair. I saw one today and he's like, I want to repair. And I figured out his numbers. He had 11. So I was like, you're going to be better off. He was a little bit older. And I said, you're going to be better off with a replacement than a repair. So this is a very simple, objective way to look at this and decide if this is a repairable tear. One of the options is debriding and partial repair. This is pretty old information, but still, it shows that if maybe you have an unhealthier patient that is wants a quick, minimally invasive procedure, they can do okay in this. But you have to tell them that there's going to be no improvement in strength or motion, but they might get some relief of some pain. And I think what this does is it serves as an interpositional graft and it stops the pain of the humeral head hitting the acromion. But these failure rates are as high as 52%. So it's a flip of a coin. So this has kind of gone out of vogue. The superior capsule, which is here. So if you look at the rotator cuff is made up of 5 layers. This thinner layer up top is the first 4. The bottom layer here, that thicker layer is the fifth, which is the superior capsule, and I'm grabbing it. One of the things you realize though is that capsule does not go all the way lateral. That capsule only goes to the medial side of the tuberosity. So if you're going to fix a tear like this, which delaminated tears don't do very well, you have to think of a lot of different ways to fix this. So you would fix this in 2 layers. You would first fix the superior capsule back down to here, and then this up and over it. If you over tension this superior capsule by going as far lateral as you can, it will fail, and it'll probably end up with a Cho type 2, which is where it tears through the myotendinous junction. So on SCR, the original data, when brought up, showed that it's probably only good for these patients with stage 1 or 2 glenohumeral arthritis. Once we start getting into these Hamada 3, 4A, 4B, and 5s, that's where, those patients are going to do better with other procedures. It's also important that if you're going to do an SCR, you have to do a margin conversion stitch to the posterior intact rotator cuff. So if their infraspinatus is intact, and theoretically an SCR is only for a single tendon irreparable tear of a supraspinatus. So you would do the SCR and sew it into the infraspinatus. And what that does is it keeps the head from buttonholing through and hitting the undersurface of the acromion. So if you don't do that, you will have no effect. If you just do the SCR, the superior migration, it's going to come right back. So it's very important that you do that component of tying it into the SCR. So this is Mahata over here. I was lucky enough that did an ICL and was able to sit with them, and I picked his brain after, and they do a totally different procedure than what we consider an SCR in the US. We have tried to use dermal allograft, which is far too thin and far too flimsy, so it really doesn't do a very good job of compressing that humeral head to stay down. What they like to do is take a big chunk of tensor fascial lata and roll it on itself. So it's about 8 millimeters thick. So there is an interpositional graft component to an SCR the way it's done in Japan. And then it's positioned appropriately from the glenoid all the way to the humerus. So the conclusions in 2026 is the younger, more active, it's just the supraspinatus and the subscap is intact. Maybe a person that you'd want to do it, but you'd want to do it with the tensor fascial lata, and many of these patients do not want an autograft. So there are some banks that will have tensor fascial lata as an allograft. I don't think dermal allograft is a good option here. And then you also want to fix what you can if there's other stuff to fix. This is one of my papers that we just published. I forgot who was on this one. I wonder if it was one of the fellows from the past. But this was an interesting one because this was an SCR I did 7 years ago. And this is what that piece of skin looked like 7 years later when I revised that patient to a total shoulder, a reverse total shoulder. So this QR code, if you want to hit it, is the paper if you want to pull it up. But what it showed is really no neovascularization. It was calcified and it was still skin. So is an SCR or is a dermis the best option for you for doing these types of procedures? The balloon interposition came out. It was pretty quick that how great it did in the US, and then all of a sudden Stryker doesn't really sell many of these anymore. And there's been a few papers and a few videos that have been shown that as the PLLA breaks down, it just makes like this snow globe within the shoulder. And that might be one of the reasons it just hasn't done as well as they probably thought. But the theory was push the head down, restore and register that glenohumeral joint. And by doing that, it pushes the head down and gives something almost like that SCR with that fulcrum that's going to push down the head in order to allow for more motion. The problem with this is in 3 months it's gone, But they tell you that it's still going to work, which I don't understand how that works if the PLLA is gone. But this is what it looks like. So pre-op to post-op, you can see the head is compressed, but long-term data other than the IDE for the original FDA submission doesn't show that those outcomes are very good. Rafi Marzain has popularized the biologic tuberoplasty, and the way he figured this out was a failed SCR. And what he realized is these patients that even if it failed, having something padding between the humerus and the acromion gave these people good function and less pain. But these were the patients that already had good motion. So you cannot have somebody with an external rotation leg or pseudoparalysis or any real arthritis. If they have good motion and their biggest issue is pain, then this is an interpositional graft that you size the appropriate size of the tuberosity and then you implant. So here's a video of one that I did. So you just prepare the tuberosity, you measure it. You can see there's no supraspinatus left, but this patient has decent range of motion. So you go to the back table and you figure out exactly what size you need. And this is the piece. Doesn't seem very big, but it's exactly the size of the tuberosity. You put some stitches in the corners, and that's how you get your lateral stuff ready. And then what we're going to do is we're going to place two knotless anchors along the medial tuberosity. And then we're going to grab those out the front and we're going to do the same thing out the back. And then once you have that, you're going to pull your passing stitches through. And these are the loop stitches, your repair stitch, and your pull stitch. So much like you would fix a labrum, and grab each of those. And then we're going to load that. And our pull stitch is going to stay out the front because that's what's going to zip line it in. You're going to do the same in the back. You got to make sure you don't have any crossing of your sutures. You're going to load this in the corner. So now you're going to pass it through that stitch. And then once you pull from the stitch in front, that's going to pull that that biologic portion over the tuberosity. So there you go. I always like to put a towel down just so I don't get any of the dirty skin on the undersurface. And then you load it up and it's going to go to where it goes because that's where our graft is. Then you're going to spread those out. Uh, you've got those two sutures on the end already positioned. So now it's just a couple of knotless anchors and it's done. It's a fairly quick procedure. You fix again what you can, and there it is. So that tuberosity can't hit the acromion anymore. One other option, oh, I'm sorry, as you go through, this is what it looks like when it's complete. And early data shows that you keep them in a sling for a very short time. They start moving. You can start them in therapy pretty quick, but it helps decrease pain. But they have to have range of motion before. Matt Ravenscroft in Manchester, England, did the opposite. He said it would be easier, and I don't even really need any anchors if I just put that dermis on the undersurface of the acromion. So again, these are just pads, but these patients must have range of motion before. I can't reiterate that enough because if you try to do this with a patient that has pseudoparalysis, they'll get really no recovery with it. This is pretty much a pain relieving procedure. So now if you have a patient that has a posterior superior tear, usually a two tendon tear, in my hands, I actually push the limits of a one tendon irreparable tear with a tendon transfer, and I can explain that in a second. So what you do here is you open up in the back, you find your lower trap, which is this area right here. We're going to elevate that off the undersurface of the scapular spine. And then we're going to load it with a graft. In the US, since we have allografts, I like to use an Achilles. In other countries, they use semitendinosus allograft or autograft or peroneus tertius. But here we'll use an allograft. And then you just go into the joint and you will fixate it here first, and then we'll go back and reattach it. And I'll show a video of that in a few minutes. But these are the ones that we know are irreparable. They're two tendon tears. They're Gatalia 3s and 4s. These are ones that Rohe score tells us that they're probably going to fail. And these are patients that are probably younger, probably in their 50s to maybe early 60s that have very limited arthritic changes. And these you can do those. I tend to throw my biceps in with it. I release it from the transverse ligament, bring it up on top, so it also serves as a little bit of a humeral depressor. But the trapezius is really nice because of where it comes from. So it's down here, and by having it down there, it's in line with the pull that you want it for an infraspinatus or a supraspinatus if you bring it up and over the humeral head. So the tenets of tendon transfers is that we want a similar excursion. We want to transfer and to be expandable. So in this case, you expand it with the Achilles. It's going to be the similar line of pull, and it's going to give us one function. So it's working with all those as opposed to a latissimus, which is an internal rotator that we're going to flip around to make an external rotator. So that's one of the reasons why I think this is a easier procedure. I also think that the radial nerve is not at risk in this procedure as it is with a latissimus. So I like using a lower trap for that reason. It's pretty easy to do. It's arthroscopically assisted. You have better restoration of the mechanics because the line of pull is the same. It's the post-operative training, so the brain can figure out how to use that as an external rotator, because essentially it's pulling on that scapula and it's going to pull on the same line. So you really don't have to teach a muscle to do something it was never meant to do. Looking at latissimus dorsi information, 25 patients here with a lat came along. When you look at these, yes, their scores get better, but a third of these people still went on to become arthritic. And if you look, you're really not getting much head coverage. You have to flip it around. Radial nerve and axillary nerve are at risk as you flip it around from the front all the way to the back. You can do some of these arthroscopically, or at least parts of them, but traditionally you're doing a big incision in the thorax, underneath the armpit, which we know is not a clean place. So it's not for me to I don't love doing these because I just don't think I can get as much out of it as I can with the lower trap. The results of lower trap have been good initially with the it's excuse me, this is still comparing the two. But the latissimus is not reproducible for all surgery. It's a very difficult procedure. You got to be careful of the pedicle. If you injure the pedicle, then you've kind of killed the muscle. It's not going to work. Lower trap is superior in restoring the native kinematics of the glenohumeral joint. El Hassan originally described it back in 2007 when he was working on these kids that had uh, these palsies, and in those issues, he found that by doing this, it restored external rotation for him. It gave him abduction, even gave him a little bit of flexion. And so he said, well, what if I did this for these patients that had irreparable cuffs? And so you can see it's not a very difficult tendon to find. It is small. Not all of them have this much tendon that you can see on the posterior side. Most often you'll see that the tendon is like almost like a pec. When you see a pec, the pec tendon tends to be more under it. So on the posterior side of it. So when you look at it from the top, you'll pull it out and say it's all muscle. But when you flip it, you'll see the tendon. Same thing here, but the opposite. It's on the front side, not the back. And once you figure that out, you can see the raphe between the lower and middle, and you elevate those. You just got to be careful not to go 2 centimeters medial to the medial scapular border when you're elevating, because that's where the spinal accessory nerve is. So here's one of my patients that this is him at 3 months. He was already starting to work. Yes, he's a pit boss, as you can see. He's dressed for the casino with the shiny suit. But this is really impressive that he has restored external rotation. He's got good forward flexion. And so this was a guy that was a 3-time loser at rotator cuff repairs and did really well with this type of procedure. And he gained a decent amount of range of motion. And that's what we've seen too, is that they all have significant improvement. Their SSVs get better, their dash scores get better, their ASES scores get better, and then the range of motion also increases. But I think it's important to know who is not a candidate. So if they have less than 60 degrees of forward flexion, they're not a candidate. So a pseudoparalytic patient is probably not going to get all their motion back. If they can get to 60, that's what we want to see. External rotation is improved. There's obviously with everything complications, and if you've ever cut into the back part of that shoulder, the skin there, it's very thick, so you have to close it in layers or you'll get seromas. But the lower trap is tends to lead to good outcomes in most patients. So here's one. So this was a case that I did where I released the suprascapular nerve first. So that's what we're doing here. And once that was released, that made it a little bit better, and there wasn't any tension on the nerve. I don't do that routinely. So this was a patient who had multiple procedures that were failures. It looks like you can fix that, but there's really not much to fix with the supra. So going back to when I started this conversation, you can use this sometimes in a supra deficient patient. Here's part of infra. I'm going to fix infra and I'm going to save some, but you can see the tissue's not very thick. It's kind of not great. So it's like, okay, I'm going to fix what I can. So I'm going to pass these two tapes and I'm going to wait a second. I'm not going to tie these down or put them down yet. But minimal arthritic changes. So that's why I think this patient's a good candidate for a lower trap. Now I'm going to take this other stitch and I'm going to try to pull this as far forward as I can and tie that down. So now I got something at least in back that's giving me a little bit of external rotation, but it's not great tissue. So then what we're going to do is we're going to debride this. I try to get all the sutures out from before, really flatten this tuberosity out, get it to bleed a little bit. Now I'm going to go underneath the undersurface of the scapular spine. I've already found the tendon. I'm going to pass my Achilles allograft here. So here it is being passed. Once I pull that through, then I can go ahead and fixate this. And it's a large, thick tendon. So what's nice about this is once you have this tendon that comes in and through, it does have a little bit of an interpositional graft component. So we're going to impact this. I'm using a knotless self-punching type anchor. So I'm going to pull this forward, and I knew I needed more supra for this guy, so that's why I'm pulling it kind of up and over. Versus if I needed more infra, I take a suture and pull it down around the side laterally, and therefore what that will do is give it more of an external rotation vector. But there it is there. We're going to screw that in. And I'm viewing through anterior lateral. I just put that first one through anterior portal. This is my posterior lateral port, and I'm waiting. It's literally waiting right there to grab those sutures and put it in. So it's not very difficult to bring that in and position it. I can speed this up a little bit. So once that's done, I will take those original two and compress this down. So not only are these through that original infraspinatus, but it's also going to compress down some of that tendon, which is what we want. Now I externally rotate the arm. So there's the inside. So I'm going to internally, externally rotate, get the creep out of the graft. So I'm going to leave that arm in maximal external rotation and abduction. So I want, when I tie this in, to have as much tension on it as possible so that I can retension the lower trap. Now I'm just going to pass it with a I'm going to grab this and just do a pulver tap weave through it. And then I'm just going to sew the Achilles in. Whatever's extra gets cut off. And so you have to tell these patients they're going to have this little bump in their back. Because remember, most of these patients will have infraspinatus wasting. So they're going to have atrophy here. So this is the only thing they'll feel. So I've gone to a smaller incision since, but you can see, take your time, find the incision, and there's your finished product. So this is what it looks like on MRI. You see the graft coming up and over and then diving down, and you see it over here, and you'll see it follow this, and you'll see the anastomosis back here. So it comes together very nicely. Last year in JSCS, we published this. Two of my colleagues, Paul Favorito and David Kummerfeld, and myself, and one of our residents wrote this paper up. 3 surgeons, 55 patients, age 59 average, 78% male. Decrease in their VAS scores, increase in their ASCS scores in all planes, and their active range of motion increased for forward flexion 25 degrees on average and external rotation in 20 degrees. But most importantly, we reversed the lag sign in 95% of the patients at 6 months. So these patients do very well. It's just there's a very stringent regimen that they have to follow. And so it's really important that you have the appropriate uh, protocol to discuss with them and give to the therapist. The biggest thing with the lower trap, however, is you need to make sure the patient will be compliant. If they're not going to be compliant, wear the sling. The sling needs to be an external rotation of about 40 degrees for about 6 weeks. If they're not going to be compliant, this is not the procedure for them. So you really have to talk them through and make sure that you have this shared decision making with your patient, that everybody's going to want to be on board with doing this and getting it done correctly. Just a quick, this is where I like to use my latissimus is grab this and bring it up for an irreparable subscap. And those tend to work very nicely as well. So in, oops, in summary, for me, a cuff repair with either a dermal allograft, which I don't use very often, but a xenograft or synthetic, I will use in a patient with thin tissue, smoker, diabetic, hypothyroid, or a revision procedure if it's a good, healthy tendon. SCR, I don't love. I've kind of taken that out of my armamentarium. I do have some of the others. I do a biologic tuberoplasty rarely, but the patient has to just have pain but good motion. If not, I go and do a lower trapezius transfer with Achilles allograft. Obviously, the next step would be replacement. And I always tell patients, worst comes to worst, even after a lower trap, if I have to do a replacement, at least you'll have external rotation when I do that replacement years, hopefully years down the line. I've yet to have to do one yet, knock on wood. And that's it. Thank you. What questions do we have?
Sharif, really enjoyed that talk.
Thank you.
So with just kind of extrapolating from other joints because I only do knee surgery these days, but when we talk about joint preservation procedures, because this is essentially the joint preservation of the shoulder, really. You know, we do osteotomies and cartilage procedures. Inevitably somebody brings up that that's going to affect the eventual total knee arthroplasty, or there's the difficulty in joint exposure because of arthrofibrosis and other things. Is there any evidence, or are there any studies now looking at lower trap transfers, reconstructions, things of that nature, that they are going to make your eventual reverse total shoulder arthroplasty more difficult, or is it going to affect the outcomes of that procedure?
So it's a wonderful question, Todd. And then I would say that with knee, that I've heard that, and obviously in those particular cases, and what you do is very unique, where you'll do a knee from beginning to end, like I do shoulder from beginning to end. And I think the problem is most joint guys aren't doing osteotomies, so they have to stomp their feet about something, and that's where they do that. In the shoulder, however, you really don't see an issue with this because it's outside of where I'm going to make my cut. I might hit an anchor, but these are calcium phosphate anchors. So usually I can pull those out. By then, the tendon is well healed. And if anything, it's the opposite. These patients do very well after it because of the fact that they now have external rotation. So the issue otherwise would be that they'd get this reverse. It'd probably give them forward flexion and abduction, but they would have very poor rotation. So this enhances their ability to regain the rotation, especially external.
You know, I think we've all seen a number of changes that have come over the years when we're talking about rotator cuff disease, patches and hemiarthroplasties and all kinds of things that kind of come and gone, like like you talk about the balloon. I know Sean Bach did some of the balloons for a little while and then quickly stopped doing those.
Mm-hmm.
And I know you're on a number of panels and things that people are talking about. What's coming next? What do you think is coming down next in the pipeline for treatment of rotator cuffs?
I think the treatment is probably more biology. I think we've come close to exhausting the technical or mechanical way we fix things. I think we have a biologic problem. I think some of these problems start in clinic with poor nutrition. Um, I think we have to optimize our patients better, knowing that we have this tendon that likes to fail when trying to be fixed. So I think we have to have better education for patients, better nutrition, better optimization. But from the standpoint of what's coming next from a biologic, I think we're going to see more. We noticed that the PRP and BMA stuff isn't helping. So it's not this endogenous or exogenous thing. I think it has to do with the way it heals. So is it a compression issue? So what I think what you're going to see in the future is probably something with collagen and compression. And what I mean by that is something that helps it heal, but then also compresses the repair down. There's new conversations regarding the enthesis site of what maybe it's not the top of the cuff that we need to worry about, but the undersurface and the interface between the bone and soft tissue. So you're starting to see a couple different companies come out with stuff like that. There's a new company called Tetris. I don't understand it because they make these holes in the bone and they plug them with an allograft and then they put the cuff over it, which seems to me like a marrow event, but taking out autologous bone to put in allograft, it doesn't make sense to me. But I think that the studies will kind of parse out what's real and what's not. But I think it's a biological component that we're heading towards.
Awesome. And my last question here
Yeah.
is because Dr. Al-Sahabi he presented some literature, I think, at our last journal club, and it's regarding the role of the acromion. Uh, are you doing with any of these procedures, doing acromioplasties? Do you
Mhm.
like to touch it? Do you leave it alone? Does it make any difference?
Yeah, so that's an interesting study by Peter McDonald and Loey El-Khattab, and it was a 10-year prospective study. What was interesting about that study is that they came out and they said that it didn't make a difference when it healed. And that's what insurance companies heard. And so they said, well, we're not going to pay for a subacromial decompression. So all of a sudden, you had all these surgeons that the conversation started of maybe I just don't do anything because it's a waste of time. However, if you look at that study, and I think Majed is on this call, those patients that had recurrent tear, I want to say were Majed, do you remember, was it
Type 2 and
like
3.
right, types twos and threes that had, but what was the number? It was like 90% of the recurrent tears had those types of
Exactly.
acromion. Yeah. So for me, I am a big fan of doing something. I don't care if I don't get paid because it just shows that what insurance picked up on was totally different than what the clinical correlation was. It might not do anything if it heals, but if it doesn't heal, it was the culprit 90% of the time. So to me, I do a subacromial decompression. I make it into a type 1. Now, if a patient looks like they're super thin tissue and it may fail, I might be a little bit more um, less aggressive or conservative with my acromioplasty. So maybe on these lower traps. I don't do much of those at all. Maybe if they have a big spur up front, but I really don't do much because I'm putting an interpositional graft and the failure is a reverse is what I'm going to do. So I'm taking that into account so I don't thin their acromion and lead them to another complication of an acromial fracture after the reverse. But I think that is a great article, but I think it was interpreted incorrectly.
Anyone else have any questions? Premier Sports, anybody?
I
Well,
do
I
not.
appreciate you guys. Oh, go ahead. Sorry, Kyle.
Oh, no, I don't. You answered. I was going to ask about like the PRP and like bone marrow stuff, but you answered that recently. So,
Yeah, the data just isn't very strong for either. If anything, I want to say Scott Rodeo published that on the medium-sized tears, PRP actually slowed down the healing. So it's kind of a difficult thing to really promote, and not to mention it's expensive for patients. So I just until there's more definitive data, I'm not a huge fan. There's definitely people around town that require it in order to do surgery and charge people about $5,000. And I think that surgeon's a lot closer to Todd than he is me, but I still see a lot of these. And that's a problem because you don't want to be that surgeon in the community that becomes known for money grabs. So until there's data, be very careful about that type of treatment of your patients.
Let me tell you about a patient I saw. Actually, she's remote, so I did a phone conversation. But she's about 58. She's got grade 3 OA of the knee and has a ACL injury. And she went to a stem cell clinic that told her, go get your ACL fixed and then come back to us because once your ACL's fixed, when we do your stem cell injection, it'll help you regrow new cartilage. So that's the BS these
Yeah, I
places are
mean,
spewing. It's just crazy.
that's exactly it. I saw a lady the other day that could not have worse cuff tear arthropathy that has spent $20,000 in each shoulder on stem cells and came to me and it's like, why does it still hurt? Well, it still hurts because you don't have a problem that needs a quote unquote stem cell. You need a problem that needs plastic and metal. And so it's just be careful. You guys are just starting into your practices and you'll be allured by the some of the financial gains of doing these types of things. But if it makes sense for your patients, do it. If it's if you have any sort of, I don't know, that's your reputation you're putting out there. And just be careful because you're great surgeons, you're great primary sports medicine physicians. The last thing you want to do is become known as the person that's selling snake oil down the street. You've worked too hard.
Sharif, thank you very much for that awesome talk, as
My
always.
pleasure. I appreciate everyone's time.